Good evening, ladies and gentlemen. My name is Dr. Femi Akinsoya. I'm a gynecologist as well as an active member of AFRH. You're all welcome to another session of our bi-monthly webinar. And just like everyone that has been part of this program will testify, it has always been very interesting, very instructive and educative. Today we have another mind-boggling topic, which is also very interesting. And today we shall be talking about recurring pregnancy losses. And our speaker today is an authority in the field, and he's really fully loaded to give us a very scintillating discussion and very interactive discussion in which most of our questions and areas that appear very vague will be addressed, and we will all be very satisfied with the discussion. So today, also with me today is Mrs. Inikpi. She's also the co-moderator, and I want to welcome as well, and then I will allow her to say one or two things. Mrs. Inikpi, you are welcome, please.
Thank you very much, sir. Okay, good afternoon, everyone. Again, we're here, another bi-weekly AFRH webinar. It's our countdown. Yeah, I'm sure we're all excited. In less than 20 days from now, we shall gather for the 2025 AFRH annual international conference. As we prepare for this landmark event, we are thrilled to share an important and historic announcement with you. For the very first time ever, we have AFRH is proud to unveil its very own AFRH mobile app. It's a simple, user-friendly, and innovative tool designed to elevate your conference experience like never before. So kindly take note of what I'm going to highlight concerning the AFRH mobile app. Of course, we'll not be using the usual hard copy program brochure. It's going to be an e-program this year. We will not print anything out. So please, you need to download the AFRH mobile app to keep abreast with what we'll be doing on a daily basis when it comes to the program. And of course, all-in-one resources from the conference details to AFRH updates, everything you need to know will be on that.
Can you hear me? Hello? Can you hear me, Mrs. Inikpi?
Very well. I can hear you loud and clear. Can you hear me? I can hear you.
Your connection is a little bit, it's breaking.
Okay, can you hear me now? I can hear you. Okay, so do well to download the mobile app. All you have to do is install on your device by clicking on the app. There's a link that has to do, it's called afrhnigeria.org/install. Then when you do that, all the other highlights will be placed before you. Follow the instruction and you'll have it installed on your device. Remember to put all your questions in the Q&A box if you have any, and it will be addressed after the discussion segment. This session is being recorded and will be available for playback after the event on our AFRH website. Kindly follow us on all our social media handle and keep abreast with what AFRH has to offer. Back to you, Dr. Adesanya. Thank you. Back to you, Dr. Oluwadare. Can you hear me, sir?
Yes, I can hear you.
Okay, sir. Thank you. Done with the announcement.
Hello. Yeah. All right. Our presenter, no other person but than is Dr. Oluwadare Adepetu. He's a distinguished consultant, obstetrician, and gynecologist with a very strong academic background. He earned his degree from Obafemi Awolowo University, Ile-Ife, and subsequently he had his residency training at Obafemi Awolowo University Teaching Hospital Complex in Ile-Ife as well, from where he became a fellow of the National Postgraduate Medical College, as well as the West African College of Surgeons. Dr. Adepetu has demonstrated in his field as an obstetrician and gynecologist, as well as a fertility expert. He's an active member of several professional organizations, including the Association for Reproductive Health, the Society for Obstetrics and Gynecology of Nigeria, SOGON, and Africa Federation of Fertility Society. Currently, Dr. Adepetu serves as the medical director of Novel Hope Medical and Fertility Center in Port Harcourt and Nigeria, where he leverages his extensive knowledge and experience to deliver exceptional care to his myriad patients with outstanding results and breakthrough in the field of fertility and the field of fertility medicine. So without much ado, I want everybody to join me in welcoming Dr. Adepetu as he begins his presentation. Dr. Adepetu, over to you.
Thank you, sir, Dr. Akinsanya. Good evening, everybody. I want to say thank you for this privilege to talk to us about the topic before us this evening. The topic before us is reproductive is a topic that bridge the gap between obstetrics and gynecology, and that topic this evening is recurrent pregnancy loss. Sorry, I'm trying to share my slide. Can you see my slide, please?
Not yet. Kindly go to file, slide sharing and...
That's what I have done. It's just not coming up. Sorry. Um, okay. Can you see the slide now?
Exactly. So, yes, we can see it now.
Again, I want to welcome everybody to this evening's presentation. I want to thank the organizers of this program for the privilege given to me to address us this evening on this important topic that we have before us. This topic is a topic that actually bridged the gap between obstetrics and gynecology, and is termed recurrent pregnancy loss. Now, to start, I'm going to go through the following outlines in making my presentation. Now, pregnancy loss is an emotional life event with significant impact on the mental health of the affected couple, especially the female partner. Now, this affected woman needs our empathy and not a blame, as because they have had enough blame in the society before getting to the hospital. And many are times when they present in the hospital, we see health practitioners trying to ask them, why did you do this? Why not present early? Why not? So this woman, most of them, these women, they go home with that guilty feeling as if they contributed to the loss of their baby. This approach to the management of this kind of patient requires multidisciplinary approach in its management. And if this is not well managed, it can result to grave emotional and social consequences. And in the past, the recurrent pregnancy loss has been given several names, including recurrent miscarriage, recurrent abortion, and we used to have a name which I think, in my own opinion, is kind of derogatory. People talk about habitual miscarriage or habitual abortion. This is like putting the blame on the woman that probably is her habit to be losing her pregnancy, and I think this should be discouraged in the management of the affected couple. Now, before we proceed, we are going to have some basic definition that will guide us in this presentation. Recurrent pregnancy loss is defined as two or more consecutive spontaneous pregnancy losses before the age of viability. And the age of viability is something that varies from one place to the other across the globe. Age of viability is defined as the age at which the fetus is capable of 50% chances of extrauterine survival when completely separated from the mother. Now, in United States, age of viability is pegged at 20 weeks, while in UK is 22 weeks. In Europe at large, 24 weeks, and here in Nigeria is 28 weeks. Now, abortion or miscarriage is defined as the spontaneous death of a pregnancy before the age of viability. So this term refer to all pregnancy losses in the first and second trimester when we limit it to Nigeria, because age of viability in Nigeria is 28 weeks. So this refers to all pregnancy losses between the first trimester and the second trimester. Now, miscarriage, abortion can also be defined as delivery of a fetus that weighs less than 500 grams with no life after complete separation from the mother. Miscarriage is used synonymously with spontaneous abortion. And in the medical world, when we say spontaneous abortion, we know we are talking about abortion that occur on its own. Then voluntary termination of pregnancy is when somebody has deliberately tampered with pregnancy. But on the street, they will prefer you call it miscarriage, so as not to say the woman is responsible or she has gone to do something to the pregnancy. So when you say abortion, they on the street they view abortion as what you have tampered with, and miscarriage as the one that occur on its own. But in the medical world, we know they are the same. It's only when we now put voluntary termination or spontaneous termination to differentiate between the two. Now, there are two types of recurrent pregnancy losses. Basically, there is primary and secondary. Primary is when a woman is having recurrent pregnancy losses when she has never carried any pregnancy beyond the age of viability, while secondary recurrent pregnancy losses is when a woman has had one or more pregnancy that she carried up to the age of viability before she starts to experience recurrent losses. Now, the recurrent pregnancy losses affect about 5% of couples. And in about 25% of cases of recurrent pregnancy losses, no apparent identifiable cause can be adduced to it. Now, recurrent pregnancy losses complicates about 15 to 20% of all pregnancies, and the incidence is about 11 to 13% when there is no prior abortion, when the woman is having the first pregnancy. Now, in those who have had one abortion, the incidence rises to about 13 to 17%, and in those with two previous abortions, 38%, while it climbs to about 55% in those who have had three previous abortions. Now, the significance of this topic is that women who has had miscarriage, instead of getting sympathy, just like I've mentioned before, and getting sympathy and support, most people, the society, even some of us in the medical world, we make them feel as if somehow it's their fault, and this is common in those who are now having needs repeatedly, and this can lead to divorce in our society, especially in our society in this part of the world where a lot of premium is placed on childbearing. Now, recurrent pregnancy losses probably has been shown to have some psychological effects than infertility itself, and this can lead to divorce, and affected couple require sympathetic management. For a woman who is not getting pregnant, who is infertile, people come around to help, to assist and give counsel, or one help or the other to help her get pregnant. But the one that is losing the pregnancy, people tend to blame her, people tend to to make it look as if she is the one responsible for our woes. So these categories of patients, they need our sympathy when they make it to the hospital. We should not join those on the street, those out there to blame them. Now, this woman needs sympathy care to allay their fears about recurrent pregnancy losses because it's something that is amenable to medical treatment. Now, we are going to go through a number of risk factors that have been adduced to recurrent pregnancy loss. One is advanced maternal age, genetic factor, anatomic, endocrine factor, infection, immunologic, thrombotic factor, and the group that is unexplained. We are going to go through this one by one. Now, the advanced maternal age. This is the most important factor when it comes to the reproduction of a woman. The higher the age of the woman, the less likely or the lower the reproductive capacity of that woman. Now, advanced maternal age adversely affect the ovarian functions, giving rise to a decline in the number of good quality oocytes, resulting in chromosomally abnormal conception that rarely develop further. This is credence is lent to this by the hypothesis that talk about limited oocyte pool. Now, advanced maternal age is directly related to chromosomal abnormality because as the woman ages, the good quality eggs they will have come out of the ovarian store and she's left with less quality oocytes. Now, the genetic factor, this can be broadly categorized into two: the parental chromosomal abnormality, which affects the husband and wife, and this which can lead to the woman having recurrent pregnancy loss, or the genetic abnormality that is seen in the fetus that the two of them produce. Now, this chromosomal abnormality can be numerical, that's what we're talking about, aneuploidy, or structural. Then it could be single gene or polygenic in nature. Now, talking about the parental chromosomal abnormality, structural genetic factor is seen in about 8% of couples with recurrent pregnancy loss. Most common abnormality is balance translocation and is twice commoner in the female parent. When karyotypic abnormality is found, genetic counseling should be provided for the affected couple. Their treatment may include artificial reproductive technology with PGD, that's IVF, with pre-implantation genetic diagnosis, or in a situation where the couple will benefit from egg recipient cycle, they can have donor egg, or if it is the man that has the problem, they can have donor sperm. Now, subsequent live birth rates in this category of people can be as high as 70%. Now, when we're talking about fetal aneuploidy, aneuploidy in fetus is mainly trisomy or monosomy, and these are the most common identified chromosomal abnormalities in humans. Now, fetal aneuploidy is the single most common cause of miscarriage. The incidence of fetal trisomy rises with increase in maternal age, and this can be adduced to what I've said earlier. As the woman ages, good quality oocytes reduces in number. Now, in general population, trisomic miscarriage does not increase the chances of having similar outcome in subsequent pregnancy. That's when we are referring to general population now. Now, anatomical factor. The anatomical factor or the anatomical abnormalities of the uterus were the first to be described as cause of recurrent pregnancy losses. Reported prevalence of uterine abnormality in the population of patients with recurrent pregnancy loss is about 15%. Uterine abnormality could be congenital or acquired. Now, the anatomical factors, the congenital ones include problems along the Mullerian duct or Mullerian system in the woman, which can lead to unicornate uterus, bicornate uterus, septate uterus, or uterus didelphys. Now, female fetus that are exposed to diethylstilbestrol in utero, this is a drug that used to be in circulation in the olden days. They usually use it to control vomiting in pregnancy. Now, if a female fetus is exposed to that in utero while in the mother, multiple anomalies such as abnormally shaped uterus, T-shaped uterus, or incompetent cervix can result from that. Then uterine abnormalities are other congenital abnormality that can cause recurrent pregnancy losses. Now, the acquired uterine abnormality can include cervical incompetence, which can result from procedures that is done to the uterus, maybe previous D&C, that's dilatation and curettage, previous tracheography, or anything done to forcefully open the cervix can lead to cervical incompetence. Now, intrauterine adhesion or Asherman syndrome, these are complications that can follow D&C or complicated abortion or septic abortion in which there is adhesion, that's gluing together, gumming together of the endometrial layer of the uterus. Now, submucous fibroid too can cause recurrent pregnancy losses. Also, endometrial polyp can cause recurrent pregnancy losses as well. Now, the Mullerian system, septate uterus account for the vast majority of patients with uterine abnormalities and recurrent pregnancy loss. This anomaly is associated with first trimester miscarriage, presumably from implantation failure or from poor vascularization. While unicornate and bicornate uterus, they are less common compared with septate uterus, and they usually account for second trimester losses. Now, cervical incompetence. This has been defined as the inability of the cervix to carry pregnancy to term due to structural or functional abnormality. And this accounts for about 20% of second trimester abortion, 8 to 15% of recurrent pregnancy losses. And diagnosis of cervical incompetence is mainly clinical when we get the typical clinical history and then transvaginal scan to assess cervical length and internal os diameter can help us. Now, when we look at these two categories, the Mullerian system and the cervical incompetence, for the Mullerian abnormalities, the gestational age, when we are taking the history, the gestational age at which this recurrent pregnancy losses occur increases. That means the first baby will come out or the abortion will occur at a gestational age that is lower than the second one. The second one will be more advanced, the third one will be more advanced. Unlike in cervical incompetence, in which the gestational age is in decreasing order. So this is an important factor that can help us to arrive at diagnosis. Now, Asherman syndrome, that's implantation is affected by intrauterine adhesion or fibrosis that occur in the endometrial layer, and it typically presents with secondary amenorrhea, hypomenorrhea, infertility, or recurrent pregnancy losses. Now, fibroid is another thing that can cause pregnancy losses. It's present in 20-30% of women in reproductive age group. But when we come to Black Africa or women of Black race, is the incidence of fibroid is higher in them. It affects more than 50% of women of Black origin, and is associated with spontaneous abortion when it is submucous, and this is related to the size and or location of the fibroid. Now, endometrial polyp. Endometrial polyp overgrowth, which is secondary to excess estrogen, their removal usually improve the outcome in women with recurrent pregnancy loss. Now, diagnosis of uterine defect, especially uterine polyp, submucous or fibroid, can be done with transvaginal ultrasound. We can do 2D, we can do 3D, plus or minus saline infusion. That's stereography, which will delineate the fibroid, the polyp, and the uterine adhesion. It will show us when we combine it with the ultrasound. That's simply passing the uterine catheter into the uterus and infuse a saline while we are carrying out the ultrasound. Now, when you infuse saline, it causes distension of the uterus, and we can see the endometrial line and see whether the polyp or any defect or any fillet defect within the endometrial endometrium. Now, HSG is another thing that can be done. That's hysterosaphingogram or saphingography. MRI too can be done. These two will show filling defects in the uterine cavity. And treatment is usually by surgical. That's hysteroscopic approach. If it's adhesion, we can go in through hysteroscope, separate the adhesion, and then that's operative hysteroscopy, and then that problem can be solved. Now, for cervical sacrilege, when there is cervical incompetence, cervical sacrilege can be inserted for cervical insufficiency. Now, cervical sacrilege is a topic that is full of many controversies ranging from the indication, whether or not it should be done, then when the indication is established, whether when to do it. Some talk about doing cervical sacrilege after the first trimester to allow for all the spontaneous pregnancy losses. But we know that there are some cases in which we have to go in earlier than that. Now, another controversy is how to do it, the method. There are various methods, McDonald, Shirotka, warm and warm, abdominal, and etc. Then how to knot your the tie. You should know how to where to put the knot. Is it at 12 o'clock? Is it at 6 o'clock? Cervical sacrilege is full of many controversies. Even after inserting the sacrilege, what to do with the patient? Should the patient stay in the hospital? How long? Then coital activity after that, and a lot of controversy. So, patient should be individualized, and practitioners should do what has been working for them when it comes to cervical sacrilege. Now we go to endocrine factor. Among the endocrine factor, progesterone deficiency, which we also known as luteal phase defect, is the commonest cause of recurrent pregnancy losses. Another thing is diabetic mellitus, that's poorly controlled diabetes. Thyroid disease can cause recurrent pregnancy loss, polycystic ovarian syndrome, and hyperprolactinemia. We're going to take these one by one too. Now, for the luteal phase defect, is a controversial etiology in natural pregnancy, unlike in IVF pregnancy. In natural pregnancy, the debate or the argument is this woman having low progesterone because the pregnancy is failing, or the woman is not producing enough progesterone due to bad pregnancy? So, in natural pregnancy, a luteal phase defect is controversial. While in IVF, we know that luteal phase defect is an established fact that can lead to pregnancy loss in IVF due to the fact that during the process of making the woman to produce during stimulation, the hormonal drugs that we use tamper with the hormones in the body of this woman, which can affect the luteal phase. Also, during oocyte pickup, when we are doing egg collection, part of the granulosal cells are aspirated along with the oocyte, and this can cause problem with corpus luteum formation, which will affect endogenously produced progesterone. That's why after IVF, all patients are routinely placed on progesterone. Now, luteal phase defect accounts for 23 to 60% of women with recurrent pregnancy loss. Pregnancy is supported in the first 10 weeks by progesterone that is produced from the corpus luteum in natural pregnancy. Now, diabetes mellitus. The problem is not diabetes. The problem is when diabetes is not well controlled. Now, uncontrolled diabetes can lead to increased abortion rates and can cause recurrent pregnancy loss. Now, in a diabetic woman, we need to check the control of this woman by checking the hemoglobin 1C level. In the first trimester, the risk is high. The risk of abortion is high if the hemoglobin 1C is very high, or the woman has not been well controlled. And we don't expect any woman or any woman that is looking forward to getting pregnant to have that is diabetic to have hemoglobin 1C that is more than 6.5%. Now, thyroid disease is another thing another endocrine factor that can lead to uh, recurrent pregnancy losses. Now, polycystic ovarian syndrome is another endocrine issue that we have identified as a cause of recurrent pregnancy loss. The prevalence based on ultrasound diagnosis is significantly higher among women with recurrent pregnancy losses, 41% versus 22% that is found in the general population. And it is believed that there is a relationship that now exists between PCOS, insulin resistant type of PCOS, and recurrent pregnancy losses. And there is higher rate of miscarriage among women with PCOS and insulin resistance that is undergoing ovulation induction compared with those who does not have insulin resistance. Now, metformin has been shown to be very good in this cohort of women. Now, hyperprolactinemia, this endocrine disorder the role in recurrent pregnancy loss is debatable, and people have associated it with that the father, the prolactin, compete with the HPO axis to result in insufficient folliculogenesis or oocyte maturation or luteal phase defect. Now, the use of bromocriptine has been shown to improve pregnancy outcome. Now, infection is another factor that has been fingered in as a cause of recurrent pregnancy loss. Any severe infection that can lead to bacteremia or viremia can cause sporadic abortion. Infection with bacteria, viruses, and other organisms such as toxoplasma, listeria can all interfere with pregnancy, but none seems to be significant cause of recurrent early miscarriage, and no infectious agent has been clearly linked with recurrent losses. No particular organism has been linked that is the cause of the first one, the cause of the second one, the cause of the third one. That's what they are trying to say there. Now, other factor that we consider is immunologic factor. And when we talk about this, chief among them is the antiphospholipid syndrome. In antiphospholipid syndrome is an autoimmune disorder that is defined by the characteristic clinical feature and the presence of the antiphospholipid antibodies, such as the lupus coagulant and or anticardiolipin antibodies. And most common complications of this disorder are venous and arterial thrombosis, in which there is damage to the blood supply to the uterus itself, and that can lead to a failed pregnancy. This increased thrombotic potential is associated with recurrent pregnancy loss. Exact mechanism by which recurrent pregnancy loss occur is unknown, but it has been linked to either impaired trophoblastic function during implantation or impaired placenta function in post-implantation period. Now, still on immunologic factor, other factors include human leukocyte antigen incompatibility, cytokine response, even ABO and rhesus incompatibility may lead to recurrent pregnancy losses, especially rhesus negative woman that has been iso-immunized. That such a woman can experience recurrent pregnancy loss. Now, thrombophilia, this thrombotic factor. Inherited thrombophilic defects, including point mutation on factor 5 leading and prothrombin gene mutation, and deficiency of prothrombin C and S, antithrombin 3 deficiency, hyperhomocystinemia. These are established causes of venous thromboembolism, and however, a definitive cause link has not been established linking them to adverse pregnancy outcome, but we know that they can cause thrombotic issue, which can affect blood supply to the uterus, thereby lead to uh, pregnancy failure. Other factors include environmental toxins, people that work in places where there are organic solvents, people who work where they spray herbicide, pesticide, those who work in industries where they use heavy metals, drug inhalation, people who take excessive alcohol, nicotine, people who work in the environment where there is ionizing radiation, then medical illnesses such as cardiac condition, renal condition, hematological condition, Crohn's disease. These are things that have been linked to recurrent pregnancy losses. Now, the management of recurrent pregnancy losses include taking detailed history from this woman, starting from biodata. Biodata can help us. With biodata, we can know the age of this woman, and we know that advanced maternal age is a risk factor. Then we can take history of the pregnancies that she has been losing them, taking detailed history. Be careful in taking this history so as not to make the woman feel bad. Now, what would the history of the pregnancy lead us to? It can help us to differentiate between pregnancy failure that is as a result of cervical incompetence and those that are resulting from malaria system disorder. Then other relevant questions to I like to rule out or rule in all the risk factors that we have mentioned are things that are essential. General examination can help us. Then pelvic examination is essential in these categories of people. With this, we can identify those with congenitally short cervix. we can identify those with that are exposed to diabetes, cholesterol in utero, in which cervix is very soft and not firm, and some other things can be uh, gotten. Now, investigation still we when a women should look into recurrent pregnancy testing after two losses, especially women in their 30s and in their 40s. Some investigations are only appropriate while the woman is pregnant, while some can be done outside pregnancy. Now, peripheral blood karyotyping of both partners is considered mandatory to find out whether there is genetic abnormality in either the male partner or the female partner. Cytogenetic testing of the abortus, when there is abortion, cytogenetic testing of that dead fetus is also good. It can help us to rule out genetic abnormality in the fetus. Now, pelvic ultrasound can help us to assess some anatomic abnormalities. If you or pelvic ultrasound using 2D or 3D can help us to identify Mullerian dot system. That's a unicornate bicornate, especially when we do 3D with reconstruction of the uterine picture on the 3D, and we'll see all these things clearly. Also, pelvic ultrasound can be used to assess the cervix. In assessing the cervix, we can check the cervical length when the woman is pregnant. In a pregnant woman, cervical length is not expected to be shorter than 2.5 centimeters in the first trimester and not be shorter than 2 centimeters in the second trimester. Also, we can measure the internal os diameter of the cervix. In the first trimester, it's not expected to be wider than 1.5 millimeter. When it's greater than 1.5 millimeter, it's strongly suggestive of cervical insufficiency, and the second trimester is not expected to be more than 20 millimeters. Now, other things that can be done include, I've mentioned peripheral karyotyping and genetic testing, ultrasound, HSG outside pregnancy. HSG can be done in which we can see the funneling shape of the uterine cavity, which can be suggestive of cervical insufficiency. Then, if there are other anatomical defects like polyp, like Asherman syndrome and all that, filling defect of the uterine cavity will be seen on HSG. Sonohysterogram, like I said the other time, also can help us to delineate when a saline infusion is done in combination with ultrasound. We can see the uterine cavity, we can see if there are polyps, we can see if there are submucous fibroid and all that. Then hysteroscopy is a new advancement in which the hysteroscope is passed into the uterus to view the uterine cavity, and all these things can be seen. And at the same time, hysteroscopic surgery can be done in which polyp can be removed, submucous fibroid can also be removed based on the competence of the operator. Now, other investigations include laparoscopy, which can be combined with hysteroscopy, then MRI, Eggers dilator test. This is an whole test that can be done outside pregnancy to check for cervical incompetence, in which it is called retrograde Eggers dilator test. Now, endocrine for endocrine disorder, we can do thyroid function test. We can do fasting blood sugar 2 hours postprandial for those that in which we are suspecting diabetes. Then mid-luteal phase progesterone can be checked to check whether the woman is having lipid luteal phase defect. Now, hormonal assay can be done in which the LH prolactin level can be assay to check for those with hyperprolactinemia. Now, for infection, full blood count, serology, that's endocervical swab can be taken to check if there is any infection that is causing the recurrent pregnancy losses. Now, for immunological test, the presence of the antiphospholipid antibodies like lupus anticoagulant, cardolipin antibodies can be checked to find out that the woman is having antiphospholipid syndrome. Now, treatment of this condition depends on the identified etiology or identified risk factors. So, if the etiology has been found, then the treatment should be tailored towards the detected etiology or the risk factor that is identified in the patient. Now, sympathetic and patient counseling. We cannot overemphasize this. We need to make this woman comfortable with us. We don't need to be judgmental. We don't need to make her feel as if it's her fault that she's having recurrent pregnancy loss. They never forget when what the experience they have with the doctor or with the medical professional. They will never forget. They can forgive people on the street, they will never forget our own. Now, at least we know that 25% of couples having this problem could have lost their pregnancies by chance. Those are the people that we don't have any reason why they have lost their pregnancy. And in this group, with only supportive care, even if we have not done anything, 75% of them can achieve life birth. So we need to be patient with them and be professional in managing these categories of patients. Now, genetic, for those that we have identified genetic factor, genetic counseling is important for them. It depends on where these genetic factors have been found. Is it in the male partner? Is it in the female partner? Now, if it's in the in whichever of them in which this genetic factor has been found, they can benefit from IVF with PGD, that's pre-implantation genetic diagnosis, in which we do IVF for them and we screen specifically for this identified genetic factor and exclude such embryos that is carrying that, but we don't transfer those ones. Then, in a situation where we cannot, this PGD cannot help them, then if the problem is coming from the woman, she can opt for donor cycle in which someone else produce the egg, or if it's affecting the man can opt for donor sperm, and we can just eliminate the genetic abnormality in the parents. Then adoption is another thing they can consider, in which they don't have to have their own biological children. Now, for anatomic problem, congenital uterine anomaly, surgical excision of the septum, in which if there is septate uterus, that's Strassman's operation, which we do, or metroplasty or stereoscopic excision can be done. For those with fibroid, mammectomy can be done. Mammectomy could be open mammectomy, stereoscopic, or laparoscopic. Now, when it is cervical incompetence, cervical sacrilege can be done. There are various methods, but the ones that are common around is McDonald, Shirodka, and all that. Now, abdominal sacrilege can be considered in those who have had previous failed transvaginal sacrilege, or those in which the cervix is so short. So abdominal cervical sacrilege can be done. Now, for those with Asherman syndrome, hysteroscopic uh, additionalisis can be done in them. Also, we should also know that in places where the hysteroscopy is not available, the good old blind additionalisis can also still be done. For those with immunologic problem, especially those with antiphospholipid syndrome, low molecular weight heparin, 5,000 international units per day or twice daily can help. Also, low dose aspirin, in which we give them 75 milligrams daily, can help them from conception up to 32 weeks. The life birth rate has been shown to be about 80 to 85% in them. Now, for those with endocrine disorder, luteal phase defect, natural progesterone can be started early in the luteal phase and continue up to 10 to 12 weeks, during which luteal placenta shift occur, and then progesterone production is taken over by placenta. Now, when it comes to luteal phase support too, there are a lot of issues around it. Route of administration, the type of progesterone to be used, for now, what studies have shown is that the best route of administration of progesterone is actually intramuscular, in which the serum level of progesterone mimic the natural progesterone or endogenously produced progesterone. But the drawback of intramuscular is pain. It's painful. So the next route is vaginal route, in which progesterone is administered through the vagina and is absorbed directly. And people have talked about the first pass of the progesterone through the uterus before it goes to other parts of the body. People also talk about progesterone patch or oral progesterone, but the drawbacks of the oral progesterone is the first pass through the liver, in which the liver degrades most of the progesterone before it gets to the target organ, which is the uterus. Now, for those with diabetes, control of the blood sugar is key. Even before the woman goes into pregnancy, we need to control the blood sugar. know we can control the blood sugar using insulin, we must know the value or the amount of required insulin per day. Then when we have achieved that, while the woman is on soluble insulin, then we can convert this to mistard, giving 2/3 in the morning, 1/3 at night. And then once we have achieved control, then the woman can now go into pregnancy. Now, thyroid disorder, the thyroid hormones too should be controlled before the woman goes into pregnancy. In those with insulin resistance, that's PCOS with insulin resistance, metformin has been shown to reduce the risk of miscarriage in them. Now, what is the prognosis? Live birth rate in women with recurrent miscarriage is associated with APS, that's antiphospholipid syndrome, is about 10% with no immunosuppressive pharmacologic intervention. If we don't do anything at all, they have 10% chances of having successful pregnancy. Now, in women with APS, fetal live birth rate is significantly improved to about 40% with low dose aspirin alone, and 70% when we combine aspirin with heparin. Now, overall prognosis is good with most couple having 60% chances of viable pregnancy. Now, in conclusion, we should know that recurrent miscarriage is very emotive. Approach should be empathic and non-judgmental. First trimester risk factor are a bit different from second trimester risk factor, and we should rely solely on our clinical skill, clinical acumen to get the clinical history. Not everyone will benefit from sacrilege. As a matter of fact, sacrilege is highly controversial. The multidisciplinary approach and experienced team is important in managing these categories of patients. Psychosocial support is very essential. And these are my references. Thank you.
Thank you very much, Dr. I'm sure everyone will agree with me that this presentation has been mouth-watering, well researched, and loaded with recent advances in the topic. So we want everyone to know that the Q&A section, the box is open. We all of us for the questions that that haven't been addressed. Kindly let's have your question in the box so that our presenter can do justice to them. Yes, I think we have a question in the box already. Someone has asked this question. Just a minute. All right. No question yet. Let me just Mrs. Inikwe to do a little bit of commercials from the association, and then we'll get back again to the presentation and questions.
Thank you very much, Dr. Femi, for the expository presentation. This is a friendly reminder to our esteemed 2025 AFRH conference delegates. We are delighted to remind you about the 15th edition of the Association for Fertility and Reproductive Health, that's AFRH Annual International Conference, scheduled to hold from September 24th to 26th, 2025 at the prestigious Lagos Oriental Hotel, Lekki Expressway, Victoria Island, Lagos. Stay connected through AFRH mobile app. Yes, this year's AFRH conference is going to be totally different. Yeah, the only way you stay connected is by downloading the AFRH mobile app. This year, there'll be no printed program or brochure for anyone to follow up with the event that's supposed to be unfolding daily. So instead, an eco-friendly AFRH mobile app will serve as your complete guide with real-time updates and a full e-program. Access this app here by following the link that is posted on the platform at app.afrhnigeria.org. How do you sign up? Open the link in your browser, click register, enter your details, verify your email, log in, and explore. And kindly note that this session has been recorded and will be available for playback on the AFRH website after this very event. To our kind notice, there'll be no webinar next week or fortnight after now due to the forthcoming AFRH International Conference. The next webinar will be resumed on the 8th of October 2025. Don't forget to follow AFRH on all our social media handles, platforms for updates. Over to you now, Dr. Kinsaya. Thank you.
Thank you, Mrs. Inikwi. And I want to believe that everyone will have registered and actually for to be part of the program that's coming up. So if you haven't registered, you've not registered to attend the conference, please rush to go and register because you can't afford to miss it. Like we said, there's a Q&A box that's available. If there are questions, okay, yes, we have some questions and comments. All right, so the first question here is actually more comments. So thank you for the insightful presentation. I noticed that multiple gestation wasn't discussed in much detail. You highlighted the risk and controversies around using cervical cerclage to prevent miscarriage. But from what I understand, in cases of multiple gestation, cervical cerclage is often considered as one of the first measures. In your view, what would be the best evidence-based approach to preventing miscarriage in multiple gestation pregnancies? And this question was actually posted by Deborah Odiga. And I don't know, would you like to take that? Or I should just read out the second one. You have a second as well that says, how can one manage PCOS before getting ready for pregnancy in order to avoid pregnancy losses later in future?
All right, thank you, sir, and thank you for your questions. Now, the first question, talking about multiple gestation. Multiple gestation, we all know, is not a normal gestation. The uterus of human is designed to carry a singleton gestation or singleton fetus. So when there are two or more, it increases the risk of early miscarriage. Then a lot of complications are associated with multiple gestation. Now, talking about cervical cerclage for multiple gestation is part of the controversies that surround cervical cerclage. Some even say it's not necessary. But when we do IVF and there are multiple gestation, everybody wants to just tie the cervix. Most of the time, evidence have shown that the doctor is probably treating himself. Most of the cerclages that are done, maybe some of them are actually not indicated. Now, going to this, so a lot cerclage is a topic that is full of controversies, a lot of controversies around cerclage. Now, talking about PCOS, for patients with PCOS, when there is PCOS, the PCOS manifests with three things. Number one is the hyperandrogenism, in which they have a lot of androgenic features like a growing ear pattern that is similar to male pattern. Then they have oligo or hypomenorrhea, then oligo ovulation. Now, pregnancy may be a bit difficult in them. Now, when pregnancy now occurs, because of the hormonal issue, because of the androgenic effect on their hormones, it causes luteal phase defect in them, and we can either take care of this prior to this woman getting pregnant, or when pregnancy has occurred, if we make diagnosis of luteal phase defect, we support the pregnancy with progesterone. those are the things we can do for her. Thank you.
Well, that's about what we have in the okay, well, there's another question there now that says 1 second, please. All right, this is okay, still the same. The person that asked the first question, they says that thank you, doctor, for explanation on and response to my previous questions. You also mentioned the role of thyroid function in miscarriage. Since we have different thyroid hormones, T3, T4, and TSH, could you clarify which of these is most significant in relation to recurrent miscarriage? Also, does the risk come mainly from hypothyroidism, hyperthyroidism, or both of them?
Thank you. For thyroid hormone, thyroid disorder, when there is hyperthyroidism or hypothyroidism, the two of them can lead to pregnancy loss. Before a patient that is having thyroid disorder gets pregnant, that patient must be rendered euthyroid. Because if there is hyperthyroidism, pregnancy can potentiate it. And there is an immunoglobulin that they produce in pregnancy that can, I'm trying to remember the name now, that acts like thyroid stimulating hormone, which can potentiate the hyperthyroidism in pregnancy and lead eventually to thyroid storm, and it can be very catastrophic. So before a woman that have thyroid disorder gets pregnant, she should be rendered euthyroid. Even the drug that they are using, the drug for treating the thyroid, propylthyroxine, carbimazole and all that. All these drugs have they can cause congenital anomaly. So she should be rendered euthyroid, and the drug should be changed in conjunction with an endocrinologist to the one that is pregnancy friendly before she's advised to go into pregnancy. Thank you.
Thank you very much, doctor. While waiting for if there are other questions, I think we still have a few more minutes. We can still take more questions and comments. There's no new addition to the question presently. Right. I want to say once again to all the participants out there that this is our bi-monthly seminar, and we had Dr. Adepetu actually, who has spoken elaborately on recurrent pregnancy losses, and the discussion has been very educative and extensive. And if there are questions or areas that need to be clarified, we still have a few more minutes. We can just put a question in the Q&A box, and it will be read out, and justice will be done to it. From today's webinar, we've actually been told that we've been told that recurrent pregnancy losses, the etiology, it's multifactorial, and it could be genetic, it could be problem with the uterus, it could be so many factors that could be responsible, and more than one factor could actually be present in an individual. And uh, uh, good evaluation and addressing each of these factors will pave way for a favorable outcome And the good thing is that most of the factors can actually be addressed, and then all the situation will definitely change. But just as the presenter has told us that a lot of support is needed, we shouldn't be judgmental when addressing this situation. And the woman is already perturbed, and she's been through a lot of emotional stress, and definitely she needs all the support and that she can get from both the doctors, the nurses, and all the caregivers together. And once we follow all that has been outlined, I'm sure the outcome will be different from what the woman has been having. And we also heard that even without doing anything but support alone, the story can definitely change and the outcome can be better. So we also want everyone to know that because of the conference that is we're having later this month, our webinar will be back again October 8th, and we need to keep the date down and be ready to participate. Okay, I think we have another question in the box. I was going to just round up and all right. So the question is, oh my, from the same person. It says, thank you for clarifying. Based on your response, I feel it's important that thyroid function testing should be considered for most pregnant women, especially those with history of miscarriage, since thyroid dysfunction doesn't always present with obvious symptoms. Many cases can be missed. For example, even after a single miscarriage, it may be worthwhile for doctors to recommend thyroid function tests. I think we should advocate more strongly for routine thyroid screening in pregnancy to help reduce the risk of miscarriage. Well, it's a comment, so that's well noted. We want to thank Deborah Odiga for the comments. Thank you very much. If there are no other questions or additions, we want to thank the presenter immensely for this scintillating and very educative and informative presentation. It's been very lucid, and virtually all the ground's been covered. And oh my, somebody just said, throw more light in causes of recurrent pregnancy losses. I'm sure he covered all that, and we don't really have much time again to go over the causes. So before we close, let me just invite Mrs. Inikpi to quickly have a recap of the information she has for us.
Okay, everyone, as I earlier stated, the mobile app, AFRH mobile app, will be our point of call for this year's international conference, and it's on the link app.afrhnigeria.org. How to sign up is open the link in your browser, click register, enter your details, verify your email, log in, and explore. As earlier mentioned, this session was recorded and will be available for playback on the AFRH website after the event. Thank you all for being available today. See you again October 8th, 2025. Thank you. Thank you.
Right. Thank you, Mrs. Inikpi. In closing, we want to thank the presenter once again and for accepting and for doing justice to the topic. And we also want to thank all the academic group behind the preparation for the webinar, and our audience again in October 8th. And I'm sure as well that it's going to be mouth-watering. So let's get set and get ready. But in interim, let's everyone go. If you haven't registered for the conference, we implore you to please go register and secure your place, and you will be glad you did. Thank you, everyone. And from Secretariat, we want to say bye for now.